Well, good morning, and thank you very much once again for this opportunity. I just want to take a moment to just sincerely thank all of you for the amazing hospitality that you've shared with me for the past 3 days. It's been amazing to meet the faculty, the residents, get to know the residents over lunch and dinner. It's really been an honor and privilege. Stan, thank you once again for taking me to the art museum, spending 3 days with me. It's been really a pleasure to spend more time with you. This morning, I'd like to talk about something that I'm very passionate about. When I started my career, my mentor said, I want you to pick one thing and one thing only. And so I picked testosterone. And so for the past 17 years, this is what I've been writing about and reading about. And so I want to share with you a journey that we've been through, and I want to share with you some of the controversies that we've had with testosterone replacement therapy over the past 15 years. So these are my disclosures, and I was part of the steering committee for the Traverse trial, which I'll be talking about today. This is the largest randomized placebo-controlled trial ever published on testosterone, and we just had our last publication come out this past January. So I'd like to share with you that today. If you treat men with testosterone, there are 5 controversies you have to be aware of. And the 5 controversies are understanding the concepts of oral testosterone, the indications for testosterone replacement therapy, testosterone and the prostate, not only prostate cancer, but also BPH, testosterone and cardiovascular risk, and finally, testosterone and fertility. So over the next hour, I'd like to share with you the current thoughts on all 5 of these controversies. Let's go back with a little bit of history. How long has testosterone been around? 1935 was when we first invented testosterone. It was the exact same year in 1935 when Boone Van Rusica actually invented oral testosterone. But there's a problem with oral testosterone. If you give someone oral testosterone, it gets degraded very quickly by the liver, and it causes hepatotoxicity. So what they did was they methylated it. And when they methylated testosterone, it was actually to go through the liver and it would last longer. But the hepatotoxicity and the elevation in liver enzymes was worse, but it was able to stay in the serum. So it was methylated. So when we were taught about oral testosterone, we were taught, don't give oral testosterone because it can cause liver cancer, hepatotoxicity, and they were right. But that's all we had for decades. And it really, if you look here, it was in the 1970s when testosterone undecanoate was first invented. So this is oral testosterone undecanoate. And one of the benefits of having oral testosterone undecanoate was that it bypassed the liver and went into the lymphatic system. Now, the problem is you got to take it 3 to 4 times a day, and you got to take it with a fatty meal. So really not ideal, but again, it did not cause hepatotoxicity. So let's look at this. So essentially what you do is you take the medication, it bypasses the liver, it goes into the thoracic duct, and it goes into the bloodstream. Gives you a very nice level, but again, 3 to 4 times a day with a fatty meal. The 1970s, the drug was called Androl, and it was available throughout the world. You can get it in Canada, you can get it in China, you can get it in South America, but you could never get it in the United States. The US FDA refused to allow Androl into the US. So while the rest of the world had an oral option, we really in the United States did not have an oral option. And this is Androl, and this was the medication that was available for many years. And they came out with these called testo caps, and essentially you had to take it 3 to 4 times a day. I want to show you what it looks like without taking food. So if you do not take a high fatty meal, there's no absorption. So it's a high fatty meal 3 to 4 times a day, or there's essentially no absorption. So this is looking at liver enzymes when you take the oral testosterone decanoate, and there again is no adverse effects on the liver, no hepatotoxicity, and no liver cancer associated with the oral testosterone. So when did we get it in the United States? It was 2019 when we received Jatenzo. Jatenzo was the first oral testosterone decanoate in the United States. Anyone in this room can prescribe it, and you can get it available at Walgreens or CVS, and it started in 2019. Now, I just want to show you the PK curves. So we talked about this a little bit yesterday. You'll get a very nice peak within several hours after taking the oral testosterone. You take it with a meal, and then you get another peak again in the evening. I don't like doing that. I like to take it at breakfast and lunch and superimpose the second curve onto the first curve. So essentially you get a great level during the day and a very low level at night, and it really mimics diurnal variation. So patients do better, I think, when you tell them to take it at breakfast and at lunch. And they tend to do better. The good news is it doesn't have to be taken 3 to 4 times a day. It's twice a day, and it doesn't have to be a fatty meal. It just has to be a meal, right? So that's one of the benefits of taking the orals. So the Every single drug that got approved, testosterone product that got approved after 2015 had to do hypertension testing. So the FDA, will go into that later why, but the oral testosterone saw about a 5 millimeter increase in systolic blood pressure, and 7% of patients who started this medication either had to start an antihypertensive or to increase their dosage. So again, starting hypertension is not unique to oral testosterone. All testosterone products cause hypertension, some more than others, particularly the injectables. And the reason being is because testosterone causes sodium retention. When you cause sodium retention, you can cause hypertension. So again, this is about 5 millimeter systolic. So one of the benefits about oral testosterone is the rate of erythrocytosis. If you look, one of the side effects of testosterone supplementation is an elevation in the red blood cell count. The injectables have the highest rate of erythrocytosis, 66%. The pellets, roughly 35%. The gels, roughly 12%, but the orals, roughly 5%. Why is that important? Because when a patient comes to me and he's on an injectable testosterone and he's getting erythrocytosis, I can have him donate blood, that's an option, or I can switch the formulation. I can switch the formulation from an injectable, preferably even to an oral, and I drop that erythrocytosis rate from 66% down to 5%, right? So it's really important to know the erythrocytosis rate on these different products, because then you can make a switch if you need to, but 5% is what you see on the orals. So in 2022, the last 2 oral testosterone products came out in the United States. So now we have 3 oral testosterone products that we can prescribe. They're all BID. They all have to be taken with a meal, not a fatty meal. And all 3 are available for you today to prescribe to patients. Now, there's some differences you should know about the 3 of them. Tolando, when they got through the FDA, only were able to get 1 dose. So it's only 1 dose. If that dose doesn't work, we're done, right? So it's no titration. So 225 milligrams BID. Kysotrex is different in the sense that Kysotrex said, we're not going to go through a pharmacy. It's cash only, and that's it. So it's $150. They ship it to your house, but they're not using a pharmacy. But they're very good. Jatenzo does use pharmacy, and it's titratable. So you can go up and down on the dose. And so there's some slight differences between all of these. In my experience, it's been a little bit tricky getting insurance coverage for a lot of these products. And so a lot of times we'll just get Kysotrex, pay the $150, comes to your house, and patients are very happy. So again, all 3 are available. They're very good. They do work at very good levels, particularly if you use it at breakfast and lunch. These patients do get very good levels, and patients seem to be very satisfied. Let's talk about another controversy, indications for testosterone therapy. And I alluded to this yesterday. So in 1981, if you open the package insert of all the testosterone products, they put in there the indications. And you'll see this in any package insert for any drug you open, they'll have the indications. And if you look at the indications for testosterone, it says androgens are indicated for the replacement in conditions associated with absence of deficiency or absence of endogenous testosterone. They list primary hypogonadism, and they list conditions. They list secondary hypogonadism, and they list conditions. Nowhere on this list do I see the word erectile dysfunction. Nowhere on this list do I see the word low libido, right? So a 55-year-old man walks into my office with a testosterone of 190. He has low energy, low libido, erectile dysfunction. I say, well, Mr. Smith must have idiopathic hypogonadism because he doesn't have any of these conditions. So the FDA in 2015 disagreed. And the FDA in 2015 put out a little statement. And they said, look, we caution that prescription testosterone products are approved only for men who have low testosterone levels caused by certain medical conditions. The benefit and safety of these medications have not been established for the treatment of low testosterone due to aging. So what did the FDA do in 2015? Here is the same indications, same primary, secondary hypogonadism. All they did was remove that word idiopathic, right? So now what the FDA is saying is, unless you have a tumor, unless you have some problem going on with the pituitary or the testicle, that patient is off label. Now, what are the implications for that? Who benefits the most? The insurance companies benefit the most, because if a drug is off label, they don't have to pay for the drug, right? So essentially, you can treat patients off label, but how many patients do you think you're treating off label with testosterone supplementation? It's roughly 85%. So 85% of patients who come into your office, they don't have a pituitary tumor, they don't have a testicular tumor, they just have low energy, low libido, and a low T, right? and 85%, so only 15% meet the criteria. Now, if you look at what the guidelines say, not the FDA, the guidelines say that's ridiculous. All you have to have is 2 low testosterone levels and signs and symptoms of hypogonadism, and you are eligible for therapy. That's the AUA guidelines, that's the endocrine guidelines, and that's simply how we could practice medicine today. But this is where you have a discrepancy of what the FDA says as an indication and what we do clinically. And remember that that's where many insurance companies say, we're not going to pay if they don't meet the indications. Now, I was fortunate to be part of the AUA ED guidelines in 2018. This is a little schematic showing if a man walks in with erectile dysfunction, we have several options. We talked about this yesterday. You can give him a pill, you can give him an injection, you can give him an implant. Let me also be clear. Nowhere on this list do I see the word testosterone. Testosterone is not listed as a treatment option for erectile dysfunction. But when we wrote the guidelines, we told all the readers to say, look, when a man walks in with erectile dysfunction, I want you to check a hemoglobin A1C. I want you to check a testosterone, and I want you to check a lipid panel. So why am I asking you to check a testosterone when that's not even a treatment option for erectile dysfunction? There's got to be a reason. And the reason is the following. When you look at the literature strongly suggests that PD5 inhibitors work optimally in the setting of eugonadal patients. In other words, if a patient is hypogonadal and they are not responding to a PD5 inhibitor, and you put that patient on testosterone supplementation, 30 to 50% of those patients will then become responders to PD5 inhibitors. And the literature was very strong. And that's why we put that in as a recommendation that, yes, if you're going to use PD5 inhibitors, make sure the patient's eugonadal. But testosterone as monotherapy should not be used, right? That's not your go-to for ED. It should be used in combination with PD5 inhibitors because they're much more effective. Now let's talk about a controversial topic that's been around for decades. And this is really this concept of testosterone causing prostate cancer and testosterone causing BPH. I want to look at the date here. The date here is 2006. Okay, so 2006, if you sent a survey out to many of the people throughout the country, they said, what is your number one concern in giving men testosterone? They said, I'm worried I'm going to give my patient prostate cancer. But over the past 20 years, there's been a huge paradigm shift. When I finished my fellowship, we were thinking that testosterone may be dangerous. Soon after that, we thought, maybe it's safe if I give men testosterone after radical prostatectomy. We're entering this new era now of testosterone being therapeutic and maybe even protective against prostate cancer. And that's what I'd like to share with you today. So in 2003, I was a third-year resident, and I was sitting in Journal Club, and I remember this article came out. And I was sitting next to a urologic oncologist, Dr. Kevin Slaywin, in Journal Club. And this was a study by Abe Morgenthaler giving men testosterone when they had high-grade PIN. And I remember distinctly, Kevin Slaywin leaned over to me and said, can you believe that Abe Morgenthaler is giving men testosterone with high-grade PIN? Doesn't he know that he's going to cause prostate cancer and these men are going to die? And this is just 20 years ago. Just 20 years ago. And that was the belief that you just do not give men testosterone if they even are remotely have any risk for having prostate cancer, just 20 years ago. So in Morgenthaler's study, no increase in prostate cancer, no progression of prostate cancer, but these are men with just high-grade PIN 20 years ago. Since this study, there are numerous studies giving men testosterone after radical prostatectomy, after radiation, brachytherapy, even active surveillance. And the majority of these studies show that there's no increased risk in biochemical recurrence or progression. Now, let's be fair. Most of these are a select population. You're selecting the least risky patients, making sure that you get a good outcome. But again, suffice it to say that numerous studies not showing any increased risk in biochemical recurrence or progression in men receiving testosterone with a history of prostate cancer. But there were some studies that pushed the envelope, and this was alluded to yesterday. This was our study in 2013. We took 103 men, hypogonadal, that received testosterone after radical prostatectomy. We had 49 eugonadal controls, and we defined high risk as patients who had positive surgical margins, Gleason 8 or higher, positive lymph nodes. And in that, we also had a control group. In the testosterone group, we had 77 men with low intermediate risk, but we had 26 men that met this high risk criteria. The control group, we had 34 men who were not high risk, 15 men who were considered high risk. What did we find? 12 men had biochemical recurrence, but only in the high-risk group after 36 months. If you received testosterone therapy, the biochemical recurrence was 15%. If you did not receive testosterone therapy, the biochemical recurrence was 53%. So let's stop there for a second and think about this. Because when I submitted this paper, the editor said, look, are you telling me that you had a biochemical recurrence rate of 15% at 3 years in that high-risk group? That's very low. That is a very low biochemical recurrence rate, 3 years in a very high-risk population. Are you suggesting in any way that testosterone may be protective against biochemical recurrence? Because it doesn't make sense. So let's look at that. So I have a basic science laboratory, and in 2000, early in 2004, 14, excuse me, we looking at prostate cancer cells in the lab. So Wei Tao Song is my technician that works in the lab. I said, Wei Tao, I want you to take many petri dishes with limb cap cells, and I want you to start putting different doses of testosterone in each one of those petri dishes, and I want you to tell me what happens. So what we did was we took limb cap cells, and if you look at this here, it doesn't matter which one you look at. When you put testosterone in cells that have prostate cancer, those cells love it, and they start to grow. That is very true. But as you give higher and higher doses of testosterone, you see greater and greater suppression of prostate cancer cell growth. We call this the inverted U. So again, maybe there's some benefit in castration, maybe there's some benefit in high levels of testosterone, but that hypogonadal range, prostate cancer cells love it. So if you take a closer look at the top here, A, B, and C, A is basically looking at no testosterone with the limb cap cells. You start adding testosterone, they like it, they grow. As you add higher and higher levels of testosterone, they start to suppress. So again, maybe the inverted U. So I said, wait out. Let's now do this in an animal model. So we took 200 mice. We said, okay, we're going to take 45 controls. We'll do orchiectomy and another 44. Orchiectomy plus low-dose testosterone, then orchiectomy plus high-dose testosterone. We injected all the mice with limb cap cells in the back, and we followed them for about 3 months, and we measured testosterone and time to tumor. So this is we use Testapel like we use in humans, but we'd cut it and measure it, and we put it underneath the skin, and we would measure the tumor on the back. And what did we find? We found the exact same thing we found in the petri dishes. If you take an animal and you do an orchiectomy, you see a significant reduction in tumor incidence rate. As we add testosterone to those animals low dose, the tumor incidence rate goes up on the back. As you add high levels of testosterone to that patient, you see a suppression in tumor incidence rate as well. It's an inverted U once again. So for me personally, if I had prostate cancer, I'd say, look, either castrate me or put me in the normal range, but I am not staying in the hypogonadal range. I firmly believe that the hypogonadal range is the danger zone when it comes to prostate cancer. Others have shown the same thing. So Stacy Loeb actually looked at a very nice registry study. It was a case control study out of Sweden, 284 patients who had prostate cancer, almost 1,400 case controls. They found no association between testosterone and prostate cancer, but patients who received testosterone therapy had lower risk of aggressive prostate cancer, and they said that this needs further investigation. Tom Allering took it to another level. He said, look, I have 850 patients after radical prostatectomy. 152 patients were low risk with no evidence of disease. And he followed these men and he put them on testosterone therapy and followed them for 3.5 years. If he put a man on testosterone after radical prostatectomy, the recurrence rate was 7.2%. If he did not put a man on testosterone after radical prostatectomy, the recurrence rate was 12.6%. And he said, look, if I put them on T, they're 54% less likely to recur. And if they do recur, it's going to be delayed by at least 1.5 years. The first time we're seeing after radical prostatectomy that maybe putting someone on testosterone may delay the biochemical recurrence rate. And I think that's very important. So now I'm going to switch gears here and talk about 4 areas. So if you're treating patients with prostate cancer, there's 4 important areas that I want to bring to your attention today. I want you to think about testosterone as a tool to help diagnose and treat men with prostate cancer. And I want you to think about low testosterone as a biomarker for deciding who has prostate cancer, low testosterone as a predictor of who will progress on active surveillance, low testosterone is a risk factor for biochemical recurrence after radical prostatectomy, and testosterone therapy as a treatment for metastatic prostate cancer, a complete paradigm shift. So let's start with the first one. So PSA has been around since the early 90s, but PSA is a bad test, but it's all we have, right? So if a patient has a PSA of 4, the threshold, the positive predictive value is 37%, negative predictive value is 91%, which translates into about 25% probability that a man in a PSA of 4 to 10 will have cancer. So we know that the problem was the positive predictive value. So what did we all do? We started getting very clever. We started inventing these new biomarkers, 5, 4K, PCA3, because if you look at the 5, 4K, PCA3, it skyrockets and bumps up our sensitivity. So now if I use one of these in addition to the PSA, I have a much better chance of finding out who really has prostate cancer. The cost of these can be a little pricey sometimes, $750, $760, but they're very useful tools in predicting who's going to have prostate cancer. But I want you to look at another biomarker. I want you to look at testosterone and look at some of the testosterone and PSA ratio. The sensitivity of that is about 82%, far greater than looking at a PSA alone. And the cost of that is roughly $39. I'll show you one study, but numerous studies have shown that testosterone alone may be a very nice biomarker in predicting who may have prostate cancer, particularly men who have testosterone less than 250 nanogram per deciliter. And we'll discuss that. So this is one of the studies analyzing testosterone and PSA, looking at the thresholds for positive predictive value and negative predictive value. And the positive predictive value was roughly 82% and 62% respectively. And the key was looking at men under PSA less than testosterone less than 250. If you remember what we discussed yesterday, there's something called the saturation curve. If you take someone's testosterone below the saturation curve, the PSA will come down with it. For example, if a man has a testosterone of 190 and a PSA of 0.4, that PSA is not 0.4. If you normalize that testosterone, that PSA is going to come to its normal level. In other words, you take a hypovolemic prostate and it gets to its euvolemic state. So if I have a man who has a PSA of 2.9 and a testosterone 190, I'm worried. It's not a 2.9, right? If I have a man who has a testosterone of 400 and his PSA is 2.9, that's reasonable. I accept it. But a hypogonadal man with a PSA, that is not the accurate PSA. It is underestimated. So using testosterone as a tool to help you predict, I think will be very helpful. And I'm not advocating to only use testosterone, but it should be used in the mix to help you decide who really is the high risk for having prostate cancer. Let's look at the second one, active surveillance. There's been a big movement to look at testosterone in men who are diagnosed with active surveillance. This is my favorite study on the active surveillance. 338 men who had a radical prostatectomy, but all of these men were great candidates for active surveillance. They just said, I can't take it anymore. You just got to take it out. So they said, fine. We take it out and we find out how many men were actually upstaged and upgraded from the active surveillance. So they looked at these men. They looked at testosterone levels before and after surgery. Again, all excellent candidates for active surveillance. And what did they find? Low serum testosterone levels were an independent predictor significantly associated with upgrading, upstaging, unfavorable disease, and positive surgical margins. So if a man is on active surveillance, they would say if the testosterone level was low, that is enough to not even put him on active surveillance, right? So just think about this. They're advocating for the fact that if a man comes in with hypogonadal and you choose active surveillance, actually that would be a mistake. They should not be on active surveillance. Now, let's take a closer look at this, because what did we do as a society when we come in and encounter patients just like this? We started coming up with genomic markers, Oncotype DX, Polaris, Decipher. That's what we use today. Say, Mr. Smith, I ran an Oncotype DX, and I think you're actually not a good candidate for active surveillance. That's what we use today. So I pulled this from the Decipher package insert. And I looked at it and I said, okay, so this is looking at the prediction of biopsies for upgrading while on active surveillance. This is upgrading on active surveillance. The sensitivity is roughly 42%. The specificity is roughly 79%. It's up to $5,000 for the Decipher. Great tool, and it gives us some sensitivity and specificity on who really should be on active surveillance. I'm going to show you the graph I had on the last page. And if you were paying attention to the upgrading, the sensitivity on just hypogonadism is 34%. The specificity is 92%. It's better than your Decipher. And the cost of this is roughly $39, right? So again, I'm not advocating to use testosterone to solely be used to predict who's going to go on active surveillance, but clearly putting this into the mix to help you decide who should go on active surveillance, I think would be very, very helpful. So let's talk about biochemical recurrence after radical prostatectomy. This is Yamamoto's study, but there are numerous studies showing that men who have low testosterone levels preoperatively, prior to radical prostatectomy, are much more likely to have a biochemical recurrence after radical prostatectomy. So Yamamoto looked at 272 patients. They all had a radical prostatectomy. He divided them into eugonadal and hypogonadal. Independent and significant predictors of PSA recurrence were, and we all know the first three, which is Gleason score, surgical margins, PSA, preoperative testosterone levels were an independent predictor. Why is that important? Because when a patient walks into my office and they say, Dr. Khera, I'm very concerned. What do you think my chances of biochemical recurrence are after radical prostatectomy? Do you know what I do? The first thing I do is I go online and I look at the Memorial Sloan Kettering Catan nomogram. I start sticking in all the variables and I say, this is your risk of biochemical recurrence. So I went to the Catan nomogram and I started pulling all the variables. And if you look at all the variables on the Catan nomogram to predict who's going to have a biochemical recurrence after radical prostatectomy, you'll see some of the similar things: PSA, positive surgical margin, Gleason score. I don't see testosterone anywhere, right? I'm not advocating to use testosterone solely as a predictor of biochemical recurrence. But if you're going to have a nomogram, testosterone should be in the nomogram as a tool to enhance your sensitivity and specificity on biochemical recurrence. And finally, this concept of bipolar androgen therapy. We talked a little bit about it yesterday. And essentially what it means is giving high doses of testosterone to men with metastatic prostate cancer. And at the same time, you're giving them Lupron. So the testosterone goes up, then it comes down. And essentially one theory is you're tricking the prostate cancer to become insensitive to then becoming sensitive. Now, if you look at the package insert and you look at the contraindications for testosterone, testosterone is contraindicated in men with advanced metastatic prostate cancer. So it's contraindicated. If you look at the indications for bipolar androgen therapy, it just means high dose testosterone. It's men with advanced prostate cancer, right? So it's very interesting. So this was the first study that came out by Schweitzer. When this came out, it was pretty impressive. This small study, 2015, out of Hopkins, 14 patients with castrate-resistant prostate cancer, high doses of testosterone, 400 milligrams IM every month for 3 months. And what did they find? They found that there was a 50% reduction in PSA, a 50% reduction in metastatic disease, right? So I just wanted, this is really unheard of to give men high doses of testosterone even 10 years ago, or 20 years ago for prostate cancer, but that's how they were treating men with prostate cancer. Since this study, there have been numerous studies looking at bipolar androgen therapy, but by far my favorite one was the Transformer study. So the Transformer study, if you haven't seen this study, I would urge you to look at it, came out in 2021. Randomized phase 2 study comparing bipolar androgen therapy versus enzalutamide in asymptomatic men with castrate-resistant metastatic prostate cancer. So these are men who had castrate-resistant metastatic prostate cancer, became resistant to abiraterone. Then the standard of care is to give them enzalutamide, standard of care. So they said, what we're going to do, instead of giving them enzalutamide, which is standard of care, we're going to randomize them to either get enzalutamide or high doses of testosterone. And let's just see what happens, right? And if they become resistant to one of those therapies, they can cross over to the other arm. So if you get testosterone, you cross over to enzalutamide, you get enzalutamide, you cross over to testosterone. Essentially, what did they find? They found there was no difference in overall survival, whether you gave this man testosterone or enzalutamide. That's a very important point. No difference in overall survival in patients getting testosterone or enzalutamide. But it gets more interesting. If you give a man testosterone and they become resistant and then you give him enzalutamide, compared to just enzalutamide alone, the overall survival was better. The overall survival was better if I gave him testosterone and then enzalutamide versus enzalutamide alone. Let's take a closer look at this. Not only was the overall survival better, but they felt better, right? Because you're giving them testosterone as opposed to enzalutamide. Let's be honest, the overall amount of survival in terms of months is not very long when you're at this stage. So some would argue the quality of life is more important than how long you live. And one would argue that the testosterone patients had a much better quality of life. So let's even look at a breakdown cost. I looked at the cost of enzalutamide online. It's roughly $7,500 a month. The cost for testosterone is about $30 a month. The efficacy, if you compare bipolar androgen therapy with enzalutamide, was the same. But if you did BAT plus Enza, it was better than Enza for overall survival. And quality of life tends to be better with BAT over enzalutamide. So again, a huge paradigm shift in talking about first the safety, then is it therapeutic, and then there's already protective effects. The paradigm is shifting, and I think you're going to see much more on bipolar androgen therapy. We were not the first to think of this. If you go and pull Huggins' article back in 1965, he was trying to tell us the exact same thing. In his article, Huggins in 1965 said that both hormonal deprivation and hormonal excess, which he termed hormonal interference, might be used for therapeutic benefit. Now, for the residents, the guidelines are important because they're going to be tested on this. The guidelines are very clear. In 2018, it says that clinicians should be informed that patients in the absence of evidence linking testosterone therapy to the development of prostate cancer. That is true. And it's a strong recommendation, but still in the guidelines, it states that if a man has a history of prostate cancer, inadequate evidence to discuss the risk-benefit ratio of testosterone therapy. So that's the test on the boards, that's the test on the exam. But again, you should be very aware of what people are doing in the community and what we're doing with the science. Now, I want to show you the final survey. So I showed you the 2006 survey of going out to many urologists. This is another survey that came out just 10 years later in 2016, going out to urologists. If you look at the very bottom, is it safe to give men testosterone after radical prostatectomy? 96% say yes. Is it safe to give men testosterone after radiation? 84% of urologists say yes. Is it safe to give men testosterone on active surveillance? 65% of urologists say yes. So again, times I think are really changing, and urologists are becoming more and more comfortable with giving testosterone to men with a history of prostate cancer. Okay, next controversy, this is an important one, is cardiovascular risk. And so I want to put this in the context of a story. In 2006, Molly Shores was the first to show that men with low testosterone levels are much more likely to die at an earlier age. She did this out of the VA. She said men who have low testosterone levels are much more likely to die, and the cause of death was a heart attack. Since Molly Shore's study in 2006, there were numerous prospective studies finding the same thing. Men with low testosterone levels were much more likely to die, and the cause of death was they were having heart attacks. So in 2014, several of us did a review article looking at all the articles we could find on testosterone and cardiovascular risk. And we found that there were numerous articles suggesting that, yes, men with low testosterone levels are much more likely to have a heart attack. If men had normal testosterone levels, it actually seemed to be protective, that they did not have an increased cardiovascular risk. But around this time, there was some controversy. If you remember this, there were 4 articles that suggested they're more likely to have a heart attack. Just 4. 3 of these articles are retrospective, non-randomized database searching articles. But again, suffice it to say, it got the attention of the FDA. So in 2015, the FDA said, look, if you want to prescribe testosterone, and if you want to manufacture testosterone, and they were talking to the testosterone industry, the companies, if you want to continue manufacturing testosterone, you got to give us a large randomized placebo-controlled trial showing us it's safe. It's going to cost $600 million. It's going to take 6 years. And if you don't do it, we're shutting it down. So guess what happened? In 2015 was the birth of the Traverse trial because they wanted to continue with this product. So there were 9 of us on this committee. There were 2 urologists, myself and Ian Thompson. There was 4 cardiologists and 3 endocrinologists. And we started our first patient in 2018. It was our first patient. And we finished our recruitment in 2022. Our first publication was last year in June. And our last publication out of the 7 studies was in January of 2024. And if you're prescribing testosterone, it's extremely important that you understand the results of the Traverse trial. So I'm going to give you very briefly the highlights so you can tell people you understand what the results were. Largest randomized placebo-controlled trial ever published on testosterone replacement therapy. You had to be between the ages of 45 and 80 to be in our trial. We wanted high-risk patients. So how can we find high-risk patients? We said, okay, if you have a history of cardiovascular disease or you have risk factors for cardiovascular disease, we'll let you be in our trial because we want patients who are more likely to have a heart attack. So again, you had to be high risk to be in the trial. Low testosterone, we ended up having 5,246 patients in our trial. Mean duration of treatment was 22 months. Mean follow-up was 33 months. So you'll see at the top, you had to have either cerebrovascular disease, peripheral vascular disease, or cardiovascular disease to be in the trial, or you had to have 3 of the 6 risk factors that you see listed below, 8 risk factors listed below, in order to be in our trial. You're randomized 1-to-1 with testosterone gel or placebo. The goal was to get the testosterone level between 350 and 750. If the hematocrit got above 54, you're excluded from the trial. And we follow these patients all the way out to 48 months with blood levels and questionnaires. Now, the way I want you to think of the endpoints are the following: primary, secondary, and tertiary, and it kind of breaks up into cardiovascular and prostate. So the primary outcome is essentially any component of MACE, meaning non-fatal MI or stroke or death due to CV causes. Secondary outcomes is if you had any cardiac procedure, such as a CABG. But we wanted to put in prostate. So secondary outcome for prostate is any high-grade prostate cancer. Tertiary cardiovascular was any hospitalization for heart failure or any VTE, thromboembolic embolism, such as PE or DVT. And tertiary outcome for prostate was any procedure for BPH, starting any patient on LUTs for alpha blocker, a alpha reductase inhibitor, or any prostate cancer we could find. So LUTs and any prostate cancer. But we threw in 5 other secondary outcomes. I wanted to know about sexual function. We wanted to know about bone mineral density. We wanted to know about depression. We know about diabetes, anemia. So we're able to get 7 studies out of the TRAVERSE trial. If you look at the baseline, average age was roughly 63 years of age. If you look at the starting testosterone was 220 nanogram per deciliter. Starting PSA was 0.9. Hematocrit was 42%. And if most of these patients had pre-existing cardiovascular disease, 54%, 45% had increased risk factors for cardiovascular disease. Majority of these patients, 84%, were on a statin as well. So here's the take home. If you started a patient on testosterone supplementation, they saw a significant increase in their serum testosterone levels, roughly 148 nanogram per deciliter, as opposed to 14 nanogram per deciliter if they were on placebo. So that makes sense. But the take home slide is this: no significant increase in cardiovascular events, roughly 7% in both groups. So now when a patient comes to you and said, I heard testosterone can cause a heart attack, you'll say, no. Have you heard of the TRAVERSE trial? There was no significant increase in cardiovascular events in men taking testosterone over placebo. Done. Finished. Right? So if you look, as I mentioned earlier, primary outcome was 7% in both groups. In secondary cardiovascular safety outcomes, no difference at all, roughly 10% as well. So no increase in CABG, PCI in both groups. In the tertiary outcomes, the component was VTE. There was no difference in a venous thrombotic embolism as a whole. If you take a slightly closer look at the components, there was a slight increase in pulmonary embolism, not statistically significant, but I just want to point it out. It was roughly 12 men out of 2,600 versus 24 men out of 2,600. It does come up. Some people say, I saw that there was a slight increased risk. I say, yeah, but it was an extra 12 men out of 2,600, and it was not statistically significant. But again, you should be aware of that. Now, there were some components that were investigator reported, means if a PI reported an increased risk, we took it down as yes. And there were 2 that you should know about: a 1% increase in atrial fibrillation and a 1% increase in acute kidney injury. Again, investigator reported. When we asked the investigator, do we think this is related to the drug itself? The majority of them said no. But again, this may come up. You say, someone says, I heard there was an increased risk in AFib. Yes, it was 1%, investigator reported, but it was 1%. So you should know about it. So what about prostate cancer? So again, looking at the entire subset of patients, 5,246 patients, looking at the risk of prostate cancer. Just so you know, if they had a PSA greater than 3 or an IPSS greater than 19, they're excluded from the study. And the take-home message is this: no increased risk in high-grade prostate cancer, no increase in any prostate cancer in those men taking testosterone over placebo, and more importantly, there was no increase in LUTs or BPH symptoms. Now, prostate cancer one I think is easy because we've seen that before, we know it, but very few studies, large studies, have confirmed that no increased risk in LUTs and BPH symptoms. Why is that important? Because if any one of us in this room opened the package insert of any of the testosterone products, the first bullet today still says patients with BPH treated with androgens are at increased risk of worsening of signs and symptoms of BPH, and they should be monitored. That's still in the package insert. But if you look at all the studies that have been out before Traverse, looking at testosterone and BPH, and you look at the right-hand column, there's no worsening of BPH symptoms. In fact, the majority of the studies would suggest that if you put a man on testosterone supplementation for long periods of time, BPH and LUTs improve in many trials, but don't show a worsening. So now with confidence, when your patient said, I read the package insert, you'll say, no, sir, did you see the results of the Traverse trial where there was no worsening of BPH and LUTs in these 5,246 patients when we put them on testosterone versus placebo? What about sexual function? This is a subset of those patients getting testosterone or gel. And the primary outcome was looking at sexual activity. The secondary outcome was looking at IIEF, erectile function and desire. And what did they find? There was a significant improvement in sexual activity in those men taking testosterone over placebo. And what's nice is that sexual activity was sustained all the way out to 2 years, right? But what they did find was that testosterone as monotherapy did not improve erectile function. Very consistent with the AUA guidelines. So testosterone as monotherapy did not improve erectile function, but it did significantly improve libido. So again, you should know that when you're prescribing patients and telling them the results of the Traverse trial. Anemia was an easy one. Taking testosterone and seeing if it improves anemia, we know that because testosterone causes erythrocytosis. So you could have predicted the outcome before you even started. But yes, those men who are anemic, you put them on testosterone supplementation, it improved their anemia. And those men who are not anemic and you put them on testosterone, it prevented anemia. End result. I just think erythrocytosis is important. This is what I talked about earlier. This is one of our studies. If you're on an injectable, you have the highest rate of erythrocytosis. If you're on the gel, you have one of the lowest rates of erythrocytosis. And remember, if you're on an oral, it drops the rate of erythrocytosis down to 5%. Just remember this. If you have a man who's developing erythrocytosis on testosterone supplementation, promise me you will send that patient for a sleep study. It's one of the easiest ways to pick up occult sleep apnea. And we diagnose so much sleep apnea in men who are started on testosterone supplementation or starting to develop erythrocytosis. Now, here were the surprises. The first surprise was looking at men looking at bone fractures. So we thought that if we gave men testosterone supplementation, we would decrease the risk of bone fractures. But the study found the opposite. In fact, those men on testosterone supplementation had a 1% higher risk of bone fractures than those men who did not. So how do we explain this? And we found that in all cases. The bone fractures occurred early within the first 6 months. They were called acute bone fractures. Remember that when you put someone on testosterone supplementation, it takes at least 6 months to see increases in bone mineral density. So we didn't have enough time. Numerous studies have shown that when you put someone on testosterone supplementation, you increase their activity. Activity levels do go up. So theoretically, if the activity level went up and they were more likely to have an injury, that could be one explanation. But again, if someone says, I saw there was an increased risk of bone fractures when I took testosterone, you will say, yes, there was a 1% increased risk, but there could be a likely explanation. And then finally, there's this concept of giving men testosterone to help with looking at depression. This is dividing the men into 3 groups. All men who were diagnosed with depression on a PHQ-9 questionnaire, and then looking at a subset of men who met the criteria of dysthymia. And what we're looking at is not only looking at depression, but we're looking at the effects on sleep quality, cognition, and energy as well. And what we found was that roughly 51% of men who had low testosterone had some degree of depression. Very similar to one of the studies we published showing that 92% of men who had low testosterone had some degree of depression. No question that men with low testosterone do suffer from depression. But they didn't actually suffer from cognition or sleep disturbances. And when we put these men on testosterone supplementation, there was an improvement in depression, statistically significant, but modest. In terms of the dysthymia patients, there was no significant improvement, but in overall depression, there was an improvement. And actually, there's one more, and this was actually on diabetes. We thought that if we put men on testosterone, we would prevent patients from developing diabetes. And we thought if we put men on testosterone, if you had diabetes or prediabetes, we could drop you down to no diabetes or prediabetes. And what we found was that when you put men on testosterone or placebo, it didn't matter. There was no effect on diabetes at all. Why this is important is that there were other studies that have shown an improvement. One's called a T4DM. When they put patients on this medication, it prevented men from progressing to diabetes. And those who had diabetes actually were downgraded to prediabetes. The difference between our study and those studies was the following. Our study just needed to have men in the testosterone range of 350 or higher. And we got kind of faulted for that because if a man came in at 290 and I got him to 360, some people would say, is that still really normal or is that still subtherapeutic? But that's the level we were going for. In all the studies that showed improvement, they were on long-acting injectable therapy like Nebido, where the levels would go up to 1,000 or 900, and that could explain the differences. Okay, so here's my summary slides. If you're going to talk to your patients about the TRAVERSE trial, this is what you're going to tell them. In terms of risk and benefit, I divided them up. So in terms of risk, no increased risk in cardiovascular events, no increased risk in prostate cancer, no increased risk in LUTS or BPH. Was there benefit in ED? No, as monotherapy, but there was benefit in libido, benefit in depression, no benefit in bone fractures, benefit in anemia, no benefit in diabetes. So kind of the take home. My last topic is going to be about fertility. And so it's kind of embarrassing. And Stan, you remember this when we sent this out to the AUA and we sent this out to urologists. And we said, is it safe to give testosterone to men who are trying to actively conceive? And roughly 25% of the urologists, these are AUA urologists, said it is okay to give a man testosterone while they're actively trying to conceive. So we are the experts when it comes to infertility, right? 25% of the experts said it's okay to give testosterone to men who are trying to conceive. We know that is not true. So if you remember the schematic, GnRH is secreted from the hypothalamus, goes to the pituitary. FSH has an S in it, so it goes to Sertoli cells. LH has an L in it, so it goes to Leydig cells. And there's a negative feedback with testosterone, and it will shut down the axis. If you give someone exogenous testosterone, what do? You shut down the entire axis. Not only do you make them infertile, but you shut down their endogenous production of testosterone. And the longer you give them the medication and the higher the doses, the harder it is to reverse. So one of the best studies, although it's older, is just giving men 200 milligrams of testosterone every week. 65% are azoospermic at 6 months. And if you stop the testosterone, 84% of them will have greater than 20 million, 46% get back to baseline at 6.7 months. Why is this important? Because if you go to many of these clinics, they say, hey, we give you testosterone, but if you stop the testosterone, you will have recovery of sperm production. And that is true. Majority of patients will have recovery of sperm production, but not necessarily back to baseline. So if I start out at 80 million sperm per ml, I take testosterone, I'm azoospermic, and I get back to 20 million sperm per ml. Yes, I have recovery, but I am not back to baseline. I am 1/4 as fertile as I was before. So be very careful on the semantics. Yes, you will have recovery of sperm production, but there's no guarantee I will get you back to baseline. And not all men have recovery. So if you are going to give men testosterone, or you want to raise their testosterone and you want to do it naturally, there are only 3 ways to do it medically. That's it. Aromatase inhibitors, HCG, or SERMs. We spent a lot of time at Baylor looking at HCG. And the reason we looked at that was there was a very nice study looking at concomitantly using HCG with testosterone. It's called the Caviola study. Can we give men testosterone and give them a protector at the same time to help them preserve their spermatogenesis? So that we got the idea from the Caviola study. So he took 29 normal volunteers. He gave them that 200 milligrams of testosterone every week, the high doses, but he gave them different doses of HCG every other day. And he measured intratesticular testosterone, because remember, that's what matters, intratesticular testosterone. And if you look at what he did, this is baseline. He gave high doses of testosterone, and the yellow is the intratesticular testosterone. So I give a man high doses of testosterone, I give him no HCG, I shut him down. I expect to shut him down. Intratesticular testosterone drops. But if you give him higher and higher doses of intratesticular testosterone, you start to preserve the higher doses of HCG, you preserve intratesticular testosterone. So very interesting. So I'm giving him exogenous testosterone, and he's still preserving his intratesticular testosterone levels. So my partner, Dr. Lipschultz, said, if that's true, I bet you he's preserving his sperm production as well. Let's study it. So the study that was presented yesterday, we took these men, gave them testosterone gel or injections. We gave them the HCG that we copied from the Caviola study at 500 units every other day, and follow-up was roughly 6 months, and there was no significant suppression in intratesticular testosterone, sperm production. And so again, you may be able to use this. I just want to be very careful. There were patients who became azoospermic. If you read our paper, they did become azoospermic. So I don't want anyone in this room to tell your patients, hey, if I put you on T and HCG, everything's going to be fine. Because there is a chance they can still become azoospermic. The majority of patients did not see azoospermia. So I just want to be very, very clear. Other options are to use SERMs. The most common SERM is clomiphene citrate. So you remember the schematic I just showed you earlier, but there's one thing I didn't show you is that testosterone gets converted into estrogen. And that estrogen can also have a negative feedback on the pituitary and hypothalamus, and it can block the receptors. When it blocks the receptors, you see actually a reduction in LH and FSH. But what does Clomid do? Clomid blocks the estrogen receptor. When it blocks the estrogen receptor, you actually see an increase in LH and FSH, and you see an increase in sperm production and endogenous testosterone production as well. So there was a shortage of Clomid. I don't know if many of you know. What we started using was another version of what we call N-clomiphene. And N-clomiphene tried to make it through the FDA back about 10 years ago. They were never able to make it. But it's actually a very clever medication. Clomid is really comprised of a cis isomer and a trans isomer. And this trans isomer is actually N-clomiphene. So they just pulled the trans isomer out and made its own medication. And the benefits of it is it has a shorter half-life, and it actually has less estrogenic effects. So we actually did a head-to-head study looking at all the men that had Clomid. We ran out of Clomid, so we switched them all to N-clomid, and we published this and we showed this at the SMSNA this past November. And the take-home message is the following. Patients who were on N-clomid actually had better testosterone levels. They had less conversion to estradiol, and they actually felt better than men who were on Clomid. One of the problems with Clomid is the following. Men need estrogen to have increased libido and sexual function. So what happens is when you give them Clomid and the testosterone goes up, 40% of those patients say, I know my testosterone went up, but I still have a low libido. You take that same patient and stop the Clomid and put them on testosterone, and then the testosterone goes up. They say my libido's back. So blocking the receptors actually has a negative effect on sexual function when you're using these medications. But the N-clomid tend to do better, had less overall side effects, it had a better effect on libido, it had a better effect on overall mood changes as well. So I'll just finally end by there are two medications out there that actually may be able to let you use exogenous testosterone and still see a benefit in preserving spermatogenesis. The first was mentioned yesterday, which is the nasal Natesto. In Dr. Ramaswamy's study, he looked at semen parameters and showed that there was no significant suppression in spermatogenesis. So again, there were some patients who did become azoospermic, so be careful. And we are now doing a clinical trial with Kysotrex. We'll be presenting, hopefully if our abstract gets accepted, we'll be presenting this in October, where we're giving patients oral testosterone. We check 6 semen analyses, 2 before, 2 in the middle, and 2 at the end. The reason we started this study was for some reason when we gave patients oral testosterone, we don't see a significant suppression in LH and FSH. And so now hopefully we're going to see no significant suppression in spermatogenesis as well. So in conclusion, oral testosterone appears to be effective and safe with minimal increase in hematocrit and blood pressure and no hepatotoxicity. The majority of men being treated with testosterone are being treated off-label today. Testosterone should be considered as a biomarker to better diagnose and treat men with prostate cancer. Testosterone has not been shown to worsen BPH and LUTs. No convincing data to support testosterone therapy increases cardiovascular risk. And lifestyle modification and SERMs are optimal ways to raise endogenous testosterone. Thank you for your attention.